Hello, everybody. I apologize deeply that I'm not able to be there in person, and I really appreciate everyone listening to me anyway. Um, Today, I want to talk to you guys about something that's a huge problem across the entire neurodevelopmental disability community, which is GI problems. Um, so, the first thing I want to do is I want to introduce you to um, my main motivation for all of this, uh, which is my daughter, Cecilia. So she is 8 years old now. She has Phelan-McDermid syndrome, which is a disorder very similar to Kleefstra syndrome. Um, she has autism, epilepsy, and some GI problems that I'll talk about here in a little bit. But this is her twin brother, Silas, who is her favorite person in the entire world. He's neurotypical, which can cause some challenges, as I think many of you experience with typical siblings. This was her during her brief foray into modeling, um, which she continues to attempt on a daily basis. And this is a more realistic viewpoint on what it's like to have a special needs child. This is one of several hospitalizations for RSV. So, what I want to talk to today about is gastrointestinal problems and autonomic dysfunction in genetic neurodevelopmental disorders. And just by way of introductions, my name's Billy Bennett. In addition to being a special needs parent, I'm also a pediatric gastroenterologist and a clinical researcher at Indiana University School of Medicine. Um, but I think a better title for this talk would be more, "Hey doc, my kid's pooping problems are utterly taking over my life. Please help." And I think this speaks to the power that the GI tract has on our daily existence and the impact that these kind of problems can have on families. So I have no direct conflicts of interests. I do receive grant funding from several organizations on this topic, and then I serve on data safety monitoring boards for several companies as an independent advisor uh, to keep an eye on safety. So let's talk a little bit about what the actual problem is. So people that have neurodevelopmental disorders have abnormal communications between the brain and the GI tract. So there's a large number of nerves that go between your brain and your intestines and stomach. And there's an entire nervous system in your GI tract called your enteric nervous system. And there are a ton of connections between those, largely mediated by something called the vagus nerve, which is a big nerve trunk that goes from your head down to your stomach. But it also has a lot of other functions, as I'll get into. And we think that the main reason that people have symptoms, things like epilepsy and autism and developmental delay, is abnormal connections and abnormal functions of the nerves inside the brain. Um, but this also extends to these same nerves and how they're structured and how they're connected, both within the GI tract and in the connections between the brain and the GI tract. And so a lot of the problems have to do with how those nerves function. Um, and then if you add into the fact that many individuals with neurodevelopmental problems are diagnosed with autism spectrum disorder, which has a lot to do with how do you receive that information. So people have problems not only with the connections, but also how they process the information that they get from those connections. So we're dealing with problems at several different levels. And I think it is worth noting at this point that we just don't know enough about the specific GI problems that exist in these disorders. Uh, and that we probably do need to have a different approach than we would in other neurotypical patients. So this is Professor Cecilia, and she agrees with the previous statements. Um, And I think this highlights the fact that we really do need to engage our children in these problems and understand what their needs are and understand the unique ways that treatment and diagnosis affects people that have higher levels of vulnerability. So there's two disorders that I want to talk about in more detail. The first one is called cyclic vomiting syndrome. So this is a variant of migraines that is more common in people that have neurodevelopmental disabilities, but it's also very common in neurotypical people. And there is a set of criteria called the Rome criteria, and we're on the fourth version of that. So it's called the Rome 4 criteria that actually define what this disorder is about. And it consists of two or more intense, unremitting episodes of vomiting that last hours to days within a 6-month period. And episodes are typically stereotypical, which means that they happen the same way, have the same symptoms every time. Episodes are often separated by weeks or months. I've had patients go years between episodes, and then there's no other explanation for symptoms. But here's where the problem comes in, is that in order to be diagnosed with this condition, you have to meet these criteria. But this last criterion right here, no other explanation for symptoms. This is where it gets hard for people that have neurodevelopmental disabilities because there often is another explanation for symptoms. So there's low tone in the GI tract, or there's a history of epilepsy, or there's multiple medications, or somebody has a history of reflux. Um, and so, sort of trying to whittle out that this is something that just happens from the nerves and isn't caused by something else is a lot more challenging in people that have more medical complexity. So, this is one of the goals that I think we should have over the next few years is to try to customize these criteria for these sort of disorders so that they actually can fit for neuroatypical people as well. Um, and I think it's worth noting that the usual pattern that people experience when they have a disorder like this is that it goes months or years before it's properly diagnosed. People go to the ER a dozen times. They're told that it's a stomach flu every single time, but nobody gets the stomach flu once a month. So how does cyclic vomiting happen? So we don't know 100%. Um, but the theory is that it is a short circuiting of the signals that come from the vagus nerve, which I talked about earlier. And it starts in your brain, but then it goes to so many other areas. So it's very heavily involved with blood vessel tone in your chest, control of your blood pressure, control of your heart rate. We think that people that get headaches, migraine headaches specifically, the vagus nerve is very heavily involved with how um, the blood vessels contract around your head. And so that does make it worse because people that have cyclic vomiting can have a lot of other symptoms. They can feel dizzy. They can look very pale. And this is what happens with many of our children is that they'll look like, oh, they look off today, or they look really pale, or they're acting like they're dizzy. Then they start vomiting. So that it's important to remember that this kind of problem, and this is similar to lots of other GI problems, sometimes GI symptoms are not the only thing people are experiencing. So that doesn't mean that it's not a GI problem that can be treated in the ways that I'll describe. But just understand that this is not isolated to one organ system. So, treatment, once somebody has an episode, we typically do what's called abortive therapy, where you're trying to stop the episode. And the number one most important thing for people to recognize during this is that fluids are essential. One of the ways that this set of nerves can be told to turn off is if the volume inside your blood vessels increases. So this is where fluids can be really helpful is if the volume increases and there's sort of a fluffing up of the space inside your blood vessels, that's a pretty strong signal to the vagus nerve that it needs to stop. and it's a pretty good way to quickly stop an episode. And we typically have people start with drinking something, so things like Pedialyte, Gatorade, if that's not available, or any kind of sports drink. I'm not advocating any particular brand, as long as there is sodium and water. And but some people do a lot better if they can get a bolus of IV fluids in the ER. So the problem here though is that when you go to the ER, if you're not dehydrated yet, a lot of times it's hard to get doctors to give your kid IV fluids. And so if you run into this problem, it's okay to tell the ER doctor, oh no, he or she does much better if they get IV fluids to stop an episode, even if they aren't dehydrated, even if urine output hasn't declined, even if they're not acting like they're dehydrated. And then the other thing that we'll use is something like Zofran or ondansetron. Um, it comes in these orally disintegrating tablets, but you can also give it IV, and this works pretty well to signal to that part of the brain that controls vomiting to just turn that switch off. And then we also will use anti-migraine medicines, so things like sumatriptan, which is Imitrex. Um, and so the thing to remember is that because this is sort of a variant of migraines, there's a lot of different migraine therapies that can work pretty well for people that have cyclic vomiting syndrome. Um, but also important is the idea of preventing an episode from happening. So, if you know that there are specific triggers, okay. Car rides are pretty common. Getting sick, so like having a respiratory illness is a common trigger. Some people can have this prolonged episode after having like the stomach flu. Um, but most of the time, there's no obvious trigger. It just comes out of the blue. And in that case, there's multiple medication options to try and prevent an episode. So my favorite is something called amitriptyline. So it's this old antidepressant from the 70s or 80s that nobody uses for that anymore. Um, and really the people that use this medicine now are GI doctors and neurologists who treat headaches. It can be sedating because it has an antihistamine effect. And then in higher doses, it can affect the heart. But we use really low doses to do this. And so in general, it doesn't cause side effects in people. I haven't seen it cause any specific problems in people with neurodevelopmental disabilities, but I will caution you that anytime a doctor says, oh, this doesn't usually cause a problem, our kids are more vulnerable. And we have to have a heightened amount of concern and care that what we're doing is not going to cause problems that aren't expected. So that's probably my favorite in this situation. Another one that I use frequently is called cyproheptadine. And one of the advantages of this medicine is it's also an appetite stimulant. So for people that have episodes of vomiting, but also have a really hard time taking in enough calories by mouth, the cyproheptadine can kind of give you a 1-2 punch. So it's also an appetite stimulant. It has the potential to be sedating as well. It's actually an old antihistamine that's not really used for that anymore. It's almost entirely used by GI doctors. Um, Another one is propranolol. So it's an old blood pressure medicine. And then there's some supplements that people will use, like coenzyme Q10 and L-carnitine. There's less evidence behind this, but I have quite a few patients that use these as well. So it's worth talking about though, why are these problems harder in people that have neurodevelopmental disabilities? We think it's more common. We think that having your nerves be a little bit out of whack from whatever your underlying diagnosis is, if it's Kleefstra, if it's Phelan-McDermid syndrome like my daughter, um, uh, is that there's probably a lower threshold that people need to cross in order to have these kind of problems. Um, but then there's other sort of complicating factors that we have to keep into mind. So one of them is that if you have an underlying diagnosis, there's a higher chance you're going to be on other medications. So it's typically not just cyclic vomiting that somebody has to deal with in this setting. Um, And if they affect something called the QTC, which is one little part of your one little part of your EKG, uh, that A lot of medicines that we use can prolong that. And so if you're on multiple medicines, I think you have to be careful about adding some of them. So Zofran can do that, amitriptyline can do that. It's a pretty common way for medicines to cause side effects. Some seizure medicines, like topiramate or Topamax, are also used for migraine and cyclic vomiting. But that can complicate things if you're also on other seizure medicines. Like, how does this affect what your neurologist says about how you're managing seizures? Sometimes appetite stimulation is not what we want. We talked about the cyproheptadine. What if your child has a problem with their weight? And adding appetite stimulation can be negative. And I think this happens in a lot of syndromes where kids are able to take things by mouth, is that there's not much inhibition of appetite. So if you throw on an appetite stimulant in someone who you can't explain the problem to, I think that makes it more complicated. Um, I think it's important to remember that there's lots of things that can make people with neurodevelopmental disabilities throw up. Seizures, a lot of kids have VP shunts or from having increased pressure in their brain. You can get gastroenteritis or stomach flu, and it can be a lot more severe. There can be behavioral causes. There's something called rumination that occurs frequently. Um, and the problem with this endless list is that everything may not be in these nice little buckets. Yes, you may have cyclic vomiting. Yes, you may have seizures, and there may be a lot of overlap. And it may be almost impossible to discern one episode as being caused by one or the other. There are a few randomized controlled trials. So these are the types of research that we do to really decide if something works. Um, that in cyclic vomiting in general, but there's none to look at specific syndromes or people that have genetic neurodevelopmental disabilities in general. So we're sort of just, you know, practicing medicine without a lot of evidence here, which is always very frustrating. Um, but the bigger thing that I mentioned earlier was that these diagnostic criteria that we have, like the way that we define the disorder, are largely validated in neurotypical patients. So how are we um, to decide what to do and who has the disorder if we can't even say for sure that that's what it is? So this is something that that we're working on with the Candid Consortium, which is something I'll talk about here in a little bit. Um, and that's one of our goals, is to develop things that are more adapted to people that are not neurotypical. Um, so a common trigger for some people is uh, lots of motion. So this is Cecilia on one of her favorite things, which is a trampoline. And uh, things like car rides can also be pretty common triggers. Uh, and of course, uh, the worst part about it is that it can be their favorite thing, and it can still be a trigger, and which is the case for her for sure. And as you can see, she's pretty pale here, although that may just be all my kids, and may not be that she's getting sick. Um, so the other common problem that I want to talk about is constipation. Uh, the average person, if they're neurotypical or not, uh, has an episode of constipation about once a month. But if you throw on a problem that causes issues with how the nerves work, then it tends to happen much more commonly. Uh, and I tend to think that constipation happens in our kids for two reasons. So one is that the enteric nervous system, which has nerves that can be out of whack, just like in the brain, it tends to have less tone. So there tend to be less signals to the muscles. The muscles tend to be weaker. So just like people can have hypotonia in their arms and legs, you can have hypotonia in your GI tract. And then add on to the fact that even when it does move, it tends to be less coordinated. So most things in the GI tract, it's sort of uh, this series of movements that we call peristalsis, where it starts at the beginning and then kind of squeezes down to move things down the intestine. Um, And in the colon, it's the same kind of thing, but it's called a mass action. And these sort of movements are less coordinated because the nerves aren't connected as well. And I think that's pretty well understood, and people have measured these things. But I think the harder part has to do with, again, those connections between the brain and the GI tract. And I think in patients with neurodevelopmental disabilities, the signals are a lot more scrambled. And then you get a signal that's more scrambled in, at your brain. And especially if somebody has a diagnosis of autism spectrum disorder, then how they interpret those signals can be out of whack as well. So you may, be told by your colon that it's time to poop, but that could be interpreted in lots of ways. It can be ignored. It could be interpreted as pain. Um, it could happen at the wrong times. Uh, so, so I think we always have to look into the fact that people that have underlying problems with their nerves don't tend to respond to a lot of these signals correctly either. And then the end result is something we call stool holding, where uh, rather than responding with "I'm going to go sit down on the toilet and I'm going to poop," kids will just hold their poop because this is an unpleasant feeling. I'm gonna try to stop it. And then after a few minutes, those signals go away for an hour or so. And then our kids are like, okay, great. I can go on with what I'm doing. And this varies a lot depending on how much developmental delay somebody has. So somebody who's not walking and is in pull-ups 24 hours a day, they can have the same sort of behaviors. But it's harder to tease out because there's not this pattern of going and sitting on the toilet. Um, the end result of all of this is that poop spends too long in the colon. And the colon's whole job is just to dry poop out. And once it gets too dry and too hard, that's when you have constipation. So all it takes is a day or two of poop in the colon sitting there too long, and then you're stuck with constipation. So how do we treat this? So we've got two different approaches, and I tend to try to use them at the same time, and to think about them both from the beginning. And it's the musher and the pusher. So the musher are stool softeners and what we call osmotic laxatives. So basically, the whole point of a musher is that you want there to be more water in the poop. So that's how poop gets hard or soft. If it sits there too long and the water gets pulled out by the colon, then it gets dry. If it goes through too fast, like if you've got an infection, then there's more water in the poop, and then you get diarrhea. So the goal with constipation, and this is kind of the first thing you always want to do. Nothing's really going to work if you can't get the poop to be soft. Um, I tend to use Miralax most often, but there's lots of choices. Lactulose is another common one. It's a sugar that our body doesn't digest, so it pulls in more water. Mineral oil works kind of similarly by because it's not going to get absorbed, so it keeps the poop softer. Lots of forms of magnesium. So there's magnesium citrate. Other magnesium supplements work the same way by pulling water um, into the intestine, so that when it gets down to the colon, then it's a lot squishier. These kind of medicines they don't really affect the body outside the GI tract. They don't affect the GI nerves. All they're doing is staying inside where the poop is, and pulling water in. And there's, people uh, have strong opinions about a lot of these medicines. But let me just say that I don't have any hesitation to give any of my kids any of these medicines for the rest of their life from a safety point of view. If they need them, then I don't worry too much about the long-term effects. There's a lot of controversy about it, um, but these are not medicines that get absorbed into your body. So their potential to cause a problem elsewhere is very close to zero. Um, Most stool softeners work better if you start out with a completely clean colon. So if you're impacted where there's a big ball of poop sitting in the rectum, things don't tend to work as well. Um, And then I usually start with, a smaller dose and then sort of ramp things up. That's after somebody has gotten, a good clean out. And 9 times out of 10, when people come to my clinic, that's the first thing I do is that they've tried Miralax, they've tried other things, and the first thing I do is say, well, let's just reset things. Let's clean stuff out so that whatever we do is actually going to work. Because if you've got a big ball of poop there, things are just going to go around it. And you want to start out just from a clean slate. And usually I'm pretty aggressive about it. Uh, it's like the same sort of thing we would do before a colonoscopy, where we just want everything squeaky clean. Um, and here's some soft serve ice cream. I just want to say that there's a myth that dairy can be constipating. Um, I think that's not a universal thing. Most of the time, it's related to high dairy diets have less fiber. But I've had plenty of patients where it's like, oh, I had one glass of milk and I was constipated the next day. So do think about how diet can affect things, but it's not consistent enough from one person to another to really say, okay, this is going to work for everybody. The main thing is really just fiber intake. If someone's not getting a lot of whole grains and fresh fruits and vegetables and things like that, then odds are they're going to need some extra help to keep more water inside your GI tract. 'Cause that's what the fiber does. It's just natural Miralax, or better put, Miralax is just fake fiber. The other thing people will use is the pusher. So this is something that actually directly stimulates um, the nerves in the GI tract, where especially the colon, and tells it to squeeze things and push things. Um, I prefer to use these most often as a second step. Like we'll try the musher first, and then if that's not working, then we'll add a pusher. Um, however, there's a lot of patients where we've been struggling for a long time with different regimens, and so we'll just start both at once, and that's okay too. They can develop dependence, but it's not the same kind of thing that we tend to think about when we say dependence on a medicine. It's more that people have a little bit of what we call a rebound when they stop it. This isn't permanent. Um, uh, I think it really isn't something that should keep people from using it, especially if they're in a vulnerable population like our kids are. Um, there's sometimes because it causes contraction of the colon, people can experience more pain. Um, and this is often caused by the actual stimulation of those nerves and squeezing of the muscles. Um, in general, these things are generally well tolerated and safe. I do have an error on here that I'm noticing. So magnesium citrate actually should have been on the previous slide. So that's an osmotic laxative. So that's not a pusher, that's a musher. But Senna and X-Lax are the ones that people tend to use the most often. But there's another half dozen or so medicines like that that work in a similar way. We also have a lot of rectal medications. So these are the kind of things that help people um, uh, relax the muscles in the bottom. So if there's stool holding, it's something that can help. Enemas and suppositories are really the things we use most often. So an enema is just liquid, like a bulb of liquid, typically saline or salt water, that's squeezed into the rectum from below, and then it liquefies everything, and then that helps kind of quickly. I mean, I guess it is a musher, but it's sort of like a right away musher. And then suppositories work in a similar way where they sort of induce the cascade of contractions that allow somebody to relax their bottom and then for poop to pass out. Um, it can be distressing for some people. I do find that a lot of children or adults that have autism spectrum disorder really do not like anything that involves stimulation of their pelvic floor, their rectum, their bottom in any way. Some people tolerate it fine. So this is something where, I think you're going to know best whether or not this is something that your child will tolerate. Um, we tend to be really careful with enemas in younger children, more infants is sort of the younger that I'm talking about here. Um, because if you're using sodium phosphate, which is a common um, electrolyte that's in enemas, that can be absorbed through the wall of your rectum. So I tend to try to just use sodium chloride or saline enemas, because the thing we always teach our medical trainees is that if you give an enema, make sure it comes out because that stuff can be absorbed. But you get past that whole problem if you just use saline enemas. The other thing that people have not been using too long, and it's almost always the first thing I recommend when somebody's come in and they've tried everything. It's rare that they've tried this. So there are specific physical therapists, and they are across the board rock stars. It's a very hard type of physical therapy to accomplish. Um, and the idea here is that uh, a lot of the reason people have a hard time pooping is how are they controlling the muscles that are involved in pooping. And just like if you hurt your arm or you injure your leg, having a professional sit down and help you learn those muscles uh, can be very helpful. And it can be a little jarring because they're talking about muscles that we don't usually talk about. Um, this is not always available depending on where you live. There's some places that have lots of pelvic floor physical therapists, some places that don't, some that are very familiar with people that have developmental delay and work with them really well. Others that tend to just see adults that have, pelvic floor problems, typically older adults or often w women after pregnancy. Um, you go into the waiting room and it'll be, the elderly women that are having a prolapse or something and or pregnant or postpartum women that need help with their pelvic floors. Um, but the hard part here is finding the right person, depending on what your kid is able to do. So that does present a problem with some forms of physical therapy. But I tend to refer just across the board. I think just some attention to physical therapy with muscles that you're using to poop. It's not going to hurt. And most people that have, um, Kleefstra syndrome or other, similar problems, already are getting different therapies, like physical therapy for other things. So adding on that series of muscles, uh, I think can often be helpful. Um, there's a last resort that we have sometimes, these surgical options. So something called a MACE, an appendicostomy, or a cecostomy. These are all just ways to get an enema in higher up. So MACE stands for Malone Antegrade Continence Enema. So an antegrade means you're going with the flow of things, and retrograde means you're going backwards. So a regular enema would be retrograde. And then these are basically, it's like a G tube, basically, that is put in at the top of the colon. And then every day you just put a flush in and it just sweeps out the colon. Um, this is something that requires testing first, typically something called a colonic manometry study or colonic motility testing, where we do a colonoscopy and place a catheter and test to make sure that all the muscles work in the colon. Because if they don't, then people tend to not be a good candidate for this kind of thing. And just you don't need to look at these numbers other than this number, the 1.4 and the 7.1. Um, that in this series of patients before they had uh, the cecostomy or the MACE, they had one bowel movement a week, and then after they got it, they had one bowel movement a day. So it can be very, very effective. Um, I'm sorry, this was a repeat slide from before. And this is Cecilia. I think she's working on a poop here. I can't say for sure. Um, so this is kind of within these two problems, the cyclic vomiting and the constipation. It's that they are present in neurotypical individuals. And this is where things are defined. And they're present within people that have neurodevelopmental disabilities. But then there's a whole lot more to it. So yes, there's overlap between what a neurotypical person experiences and what someone with a neurodevelopmental in general, because there's 1,000 of them. Um, and this is why I like talking to, your community and other communities is because I think we have a lot more in common than we have that's different. But then each of these communities also has unique challenges, other organ systems that are affected, specific genes that do very specific things. So this is sort of what we deal with in the rare disease space, is that most care is developed over here in the green, and then we have a lot in common, but then we have things that are unique to our communities that we have to account for. And so that's where kind of the two efforts need to the way that we deal with GI problems moving forward, in my opinion, is that we have to look at where things are common, in our kids and neurotypical people, um, and really adapt things to that. But then at the same time, we also have to look at what we're doing in the setting of each individual syndrome, and this is hard. It takes a lot of work. So kind of the beginning of these efforts was something called CANDID, or the Consortium for Autism, Neurodevelopmental Disorders, and Digestive Diseases. I like to do acronyms for our studies because it's easy to remember. Um, and then the website for this is candidgi.com if you guys are interested. There's a bunch of videos from the conference and talks about some of our efforts. So we had a survey before we had this conference, and we got 717 people to participate. It was all anonymous. Some people in your community participated. The main goal was to just figure out what the impact of GI problems are on quality of life. Um, but sort of a sneakier goal that we had was to show how inadequate a lot of these measures that we do are. I'm gonna guess this is an 11-month old photo. I think she's done pooping at this point. It's taken 5 months. Um, so the first thing I want to show you is what people had to say about doing this survey. People did not hold back, and I really appreciate that. This was sort of what I was hoping for, is that we would get some feedback that these measures that we tend to use aren't that effective or are more challenging in people that have neurodevelopmental disabilities. So this person said the survey was incredibly difficult to complete given the wording of the questions. So the wording of the questions didn't fit what we need to be asked in our kids. So for instance, you can't say, um, you know, in a person that's non-speaking, you can't ask, okay, are you having pain in the upper part of your stomach for the past 2 hours? Like you have to rely on behavioral cues and lots of other things. So then a lot of the questions that are just standard in these assessment tools don't work for our kids. Um, Right, as exactly what this parent said was that how can we it'd be great if we could work together to understand the quality of life, but all the tools that we have questions that can't be answered if someone is not speaking. And Cecilia is not like that at all. She's like, what is up with that? There's a possibility that she might actually be trying to catch rain here. But I think this is it's like somebody who's driving. It's like, you cut me off. Um, so the other problem is that respondents tend to drop off, I'm sorry, drop out, because if they're frustrated with taking these instruments, they tend to not finish things, which is a huge problem. Um, and people had to take wild guesses. The information that we're getting from these are inaccurate. Um, and I just that this to me is my favorite quote from this whole thing. I feel like my responses were garbage. And that is completely legitimate. I completely agree with that. And we need better ways to measure this stuff. Um, and then this gets at something that I think hits me a lot, which is that I wouldn't have to deal with this if my kid were neurotypical. And a lot of you uh, have other kids that are neurotypical, and you know that experience. There's a lot of families where the only thing that they know about parenting is to have a child that has a developmental disability. Um, and I think regardless what parents feel whenever they're trying to help their kid is, this isn't fair. You feel marginalized. You're the differentness of your experience and your child's experience is just mo much more prominent in this situation. Um, the other problem we run into is timing, you know, like, oh, you ask about how things have been in the past week or month or whatever. But what if it's something that doesn't happen that often? It can be a challenge, especially when um, somebody only has symptoms in episodes. So the sort of takeaways that we had from and just as a side note, qualitative research is something where you talk to people and you hear what they say rather than get numbers from them. I'll show you the numbers part or the quantitative here next. So I think we need to involve families much more than they're typically involved um, in developing ways to measure things and ways to diagnose things. One of the research units that I supervise at in Indiana University is uh, something called our patient engagement core. So this is something that we're trying to work on is ways to, from the very start, involve families, get their perspectives, have them design the tools that we're using to measure these things rather than have researchers design the tools. And we do it along with researchers, of course, because there's standards that you have to meet. Um, but I think that this is the most important part is that we need to have involvement of families in how we're doing this, and not just as a tokenized aspect down the road, but like from the beginning. Things need to be brief and easy and relevant. They need to account for people that are non-speaking or limited communications. We need to understand that a lot of kids have altered pain sensation or have trouble processing sensory information, so we have to take that into account. We have to take into account medical complexity. There could be multiple GI problems. You could be constipated and be vomiting. And those two could play off of each other. Um, and I think we always say in pediatrics that children aren't little adults. I really want the medical community to recognize that our kids, the neuroatypical people, they aren't partial human beings. Their humanity isn't uh, just the stuff that they can do. They are complete humans. And that complexity needs to be acknowledged and accounted for in everything that we do, in how we treat things, how we measure things, how we diagnose things. So here's some numbers. So this was from that 700 some odd patients that were part of this. Most respondents, and these were parents that responded, of course, and other caregivers. Um, Most of them were under 18. Um, So this is an incident 4 or 5 years ago where Cecilia decided to dive out of a pack and play, and she's very proud of herself. Doesn't even seem to know she's hurt. This was not a diverse sample. Most people were non-Hispanic. Most people were white. Cecilia wants us to have more diversity. Um, Gender was fairly evenly balanced. I got eye color just for fun. My kids have blue eyes, so I was, hoping for blue to win, but unfortunately. Um, and then all my kids have red hair, and that was a shocking loss right there, as you can see. Um, so this is the part that hopefully will interest you guys. I think Kleefstra did a very strong showing. Um, you guys should be very proud of yourselves for sure. Um, I will say that Phelan-McDermid syndrome, I think we really I think won, I guess is the word that I would use. Um, I talked to the CDKL5 folks a couple weeks ago, and you guys were pretty close. But I just want to say I very much appreciate your community's participation in this. It's been hugely helpful. It's given us a lot of information that we can then use to go after other funding and develop more collaborations to try and improve what we're doing for GI stuff. Constipation tended to be the dominant um, GI problem that parents identified, and that does not surprise me. That's exactly what I would expect to hear from my own practice. And so just to get you a sense of what numbers we got. So uh, these are instruments that are used to measure quality of life. So PEDS QL, quality of life. And the idea is that um, it's a number from 0 to 100, where 100 is my life is amazing and 0 is I'm suffering. And as you can see, it's kind of a fairly broad distribution of numbers depending on age. You can see anywhere from about 30 up to 100. And this is just quality of life related to GI symptoms. And then, in older patients, right around 60 or so was the average. So only problem is that the average PedsQL score for healthy controls is 88. Okay. So if you look at these numbers, that would be if everybody clustered right around here. But look at all the people that are further down the line. So what that tells us is that there are a lot of people that are suffering. This is a numeric way to say GI problems are causing our kids to suffer. There's tends to be more uh, this tends to be a problem more in older patients. I don't have a good explanation for that. My my theory is that this is because a lot of these problems tend to become progressive over time. So this was another scale, very similar, called the Promise. Only this is different in that it's made so that 50 in the middle is I'm doing great, I'm doing fine. And then the more you get over to the right, the more impact this has on your quality of life. So as you can see, same thing. This is all shifted to the right. Um, Abdominal pain has a big impact. Constipation has a big impact. And again, it should be clustered around 50. In all of these cases, these numbers are pushed over to the right, which tells us that, again, this is numerically telling us that there's suffering that's happening from this. Um, and this is something called a T-score. And if you really want to hurt your brain, then you can go read about it on Wikipedia. Um, but I think the key here is that for this particular measure, constipation and abdominal pain were significantly more impactful than other symptoms. Um, so, and this is with bad data. This is, it's very clear that this is a problem, even when the data that we got weren't great. Um, And imagine how fine-tuned we can be and how specific we can be if we can develop measures that tell us this more accurately. So I just want to remind you all that all the problems that the families identified, that 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 I mean, these are numbers that came with that in mind. Um, this is a measure that Dr. Margolis, who's a pediatric gastroenterologist in New York, um, that she developed to try to fix this, to try to say, well, uh, how can we screen for GI problems in people with ASD? And we need more efforts like this for sure. So let me just kind of close with what I think we should do next. Um, and this is, by no means a consensus across my profession. This is largely my opinion. Um, but we need to be more inclusive. I think research in general and uh, medical care in general needs to be more inclusive of individuals with neurodevelopmental disorders and autism spectrum disorder. We need to develop a pretty thorough and extensive toolbox of measures that can be used to diagnose GI problems in people that have rare diseases, neurological complexity, autism spectrum disorder, and so forth. And we need commitment from funding agencies that they will work on this. And there's been some success with this. We really pushed um, NIH a few years ago to release some specific funding announcements for GI problems in people that have neurodevelopmental disabilities, and they've come through and done that, which is really validating. Uh, it's very important that we share data. Like we have all of these different foundations and syndromes, and there's a lot of really awesome efforts that people besides me are undertaking to try and centralize a lot of these data so that we can share what successes and struggles that we've had, so that we're not reinventing the wheel every time with every syndrome. We really need to enhance medical education so that during training, people are learning how to take care, um, uh, of our complex children. Um, and I mean, I for one would like for the doctor to have at least Googled my kid's rare disorder before I walk in the room. I mean, I do it, um, and it's not hard. The Wikipedia page will give you more information than most doctors tend to have for rare disorders, and I'm fine. Um, but that just points to the fact that we just need more broad medical education about how to take care of our kids. Um, and then just, some unsolicited advice about GI stuff that I may not have covered. Um, avoid excessive antibiotics. Your uh, your colon has a lot of bacteria that need in that population needs to be maintained, and antibiotics can wipe it out. And most of the time that people get antibiotics, they don't need it. Typically, it's for something viral. So really be thoughtful and judicious, and if somebody's giving your kid antibiotics, go, are we sure this is a bacteria? Avoid overuse of procedures and tests. Um, People that have special needs tend to get more diagnostic testing, not necessarily because they need it, but because it's harder to diagnose things. And so, just be wary of the fact that as doctors, we do tend to overdo it. I am certainly guilty of that myself. But every time you have anesthesia and every time you have a CT scan or something like that, there is risk that's introduced. Avoid going to the ER if you can. Uh, ERs are great, fantastic for making sure that you're alive and getting you to the place to keep you alive. They are not great at figuring out chronic problems. They don't have the training or the resources to do that. So just, if you can avoid the ER, and sometimes you can't. Um, but there's a lot of dissatisfaction people have with using the ER to deal with chronic problems. Diet plays a fairly minor role in all of this. You need fiber to poop well, but and a lot of people really want diet to be the answer, but I think it's a relatively small part of the puzzle. Uh, if you have the opportunity, vaccinate against preventable serious GI problems like rotavirus and hepatitis. Um, I forgot to change the slide. This is PMS or Phelan-McDermid syndrome, but Kleefstra syndrome patients are much more vulnerable if they catch things like this. So that's just a general. This is just a pediatrician telling you guys this that vaccine preventable things are preventable. So do your best to prevent them. Um, there are lots of people out there that are going to confidently proclaim that they have a cure for something with a specific diet or supplement or something like that. Um, just be careful. Uh, a lot of times when people want to sell you something, they're looking for desperate people. And we're in a parent community where people are very desperate. So, um, just be very careful that if something has not been studied for safety or effectiveness, or if the person that is providing it for you is benefiting financially, just pause for a second and think whether or not this is something that makes sense. Um, our children are also unique. Um, not all doctors are created equal. Uh, find the right one for you. Um, our kids need people that have experience, not necessarily, if not with your child's diagnosis, with similar ones. And it's worth, like Cecilia sees people at 4 or 5 different hospitals. Sometimes it's very hard to find the right person. But if your, care team has people that are not meeting your needs, it's okay to look for somebody that does. Don't ever feel guilty about switching doctors. And then finally, everything is a balance. I talk about all these medicines like they're, you know, without really looking into deeply a lot of the risks. And some of these things are hard to predict for your kids, but you get to decide. Everything is a balance between risk and benefit, but you get to decide. These are your children. Um, and just keep getting advice until you feel comfortable making the decision because you have to make decisions for them. And it's very hard. Um, and so since I unfortunately can't be there to take questions live, which is the saddest part, I'm happy to take questions though. If you guys want to submit them electronically, um, via email, I can either do a follow-up video to answer questions, or I can answer them in a written form, whichever you like. Um, and I just want to say that it's been a pleasure, and uh, thank you so much for giving me the opportunity to talk about my favorite topic. And then, hopefully next time I'm able to see everybody in person. Everybody have a great conference, and have, a great weekend.